Welcome, everyone. My name is Yi. I'm your host for Occupational Medicine Pearls podcast. Today, we are looking into a topic that every occupational health professional will encounter sooner or later: asbestos. It is one of the hazards that sit in our Australian history, regulation, pathology, and the clinical judgment. And despite decades of regulation, it is still with us, among us, and we're inhaling many fibers every day. So we need to know, as a clinician, how to go forward. Let's start. Asbestos is a naturally occurring mineral and can typically be found in rocks, sediments, or soil. It has strong fibers and that are heat resistant and have good insulating properties. Because of these properties, it has been seen as being very useful for building products, and that was the whole reason how it started the industry almost 100 years ago. Based on the physical appearance, we can divide that into serpentine or amphiboly. So serpentine, it looks like a snake or serpent, and where amphiboly is more like a needle-like threads. In the serpentine, we have cryocetyle, which is white asbestos, and in the amphibole, it can be amosite, which is brown, tremolite, actinolite, crassitolite, which is blue asbestos, and anthophyllite. So there are 5 different classifications under amphiboly. When we are looking at work activities that may represent high-risk exposure, legacy-wise, it used to be miners and millers or who were involved in manufacturing. These days, most hazardous work with asbestos is more to do with licensed asbestos removalists and demolition workers. And if you work in the ceiling spaces where asbestos could still be found, and if you are workers who demolish buildings and maintain and potentially disturbing the asbestos-containing material. From the environment, non-occupational exposure, there are asbestos material in our buildings that are still there, home renovations, and there is always background level. When we are outdoors, there are fibers in the amount of 0.0005 fibers per mil, and in the indoors, 0.002 fibers per mil. And background mesothelioma rate is less than 1 per million per year. By comparison, the annual death rate for 40 years old male in 2008 was 1.6 per thousand, or 1600 per million. So we need to understand the statistic in its context. When we are looking at health monitoring for the workers who are handling and dealing with asbestos are required to have health assessment. So to do that, we collect information about demographics, medical and occupational history, records of personal exposure that include previous employment, non-occupational exposure, and current exposure. And then the doctor or the nurse will conduct physical examination. Before starting any work, baseline spirometry has to be done. That gives us a good idea where that person is. There is no set time frame or frequency for asbestos medical. Usually that was done 2 yearly, or more often if it is needed. There has to be standardized respiratory questionnaire during monitoring, and chest x-ray spirometry are done when they are clinically needed. To set the workplace exposure standard, for 8 hours, it is set as 0.1 fiber per mil. And if a worker had incidental exposure to asbestos material, there is no set follow-up protocol for any cell surveillance or post-exposure prophylaxis. We also do not recommend chest x-ray after a single event of exposure. One thing that we need to emphasize is that smoking can amplify risk of harm related to any respiratory condition, and asbestos is not an exception. So we have to take this opportunity to educate workers on reducing smoking or giving up smoking. Australia banned any importation of asbestos-containing materials since 2003, and we do not produce any further asbestos mineral or materials in the industry. So almost all the exposure would happen from environment as well as from the buildings. Banning of the importation do not remove the material that are still available in our environment. However, due diligence need to be applied when we are conducting health assessment and providing health education to the workers. After the health assessment, we will need to look at the exposure pathway. The harm from asbestos fibers depends on the fiber type, fiber size and shape, concentration, otherwise dose, and duration of exposure. Regardless of how scary you might feel like asbestos, it still follows the dose-effect relationship in most of the effects it causes to humans' health. What is a respirable fiber? A respirable fiber is classified if it is longer than 5 micrometer in length and it is smaller than 3 micrometer in diameter and aspect ratio. It's like, television 16:9 ratio. So aspect ratio length with width has to be more than 3:1. In other words, it has to be long, thread-like, and narrow to go into our airways. These definitions are based on what we can see under the phase contrast microscopy or PCM, and they are used to count fibers. And you have to imagine workplace exposure standard is 0.15. If we look at health effects of asbestos, we can see a few different classifications. We start with lungs and pleura. It can cause pleural plaques, pleural fibrosis, asbestosis, mesothelioma, and lung cancer. Looking at pleural plaques, it is a pathological diagnosis or it is a radiological diagnosis. It is not something we will find out on the auscultation or physical examination, and most workers would not have any symptoms. However, it could be identified during health surveillance. That's the whole reason we are doing that, right? So what is pleural plaque? So pleural plaque is a focal area of dense acellular hyalinized collagen. Usually they accumulate in parietal pleura. They have predilection for posterolateral chest wall, diaphragm, and mediastinal pleura. They may be calcified depending on how long it has been there. And it may be seen after 20 or 30 years post-exposure. When you do the chest X-ray, we can see that it could be well-defined bilateral pleural thickening, and they may have increased appearance or whiteness if there is calcification. On the high-resolution CT scan, we can see as sharply demarcated plaques varying costophrenic angle. Lung function or spirometry should be normal, or if there are mild restriction could still be there, but they are more likely due to other factors such as smoking. Pleural plaques themselves do not become lung cancer, but they are a marker of exposure, and there is increased risk of lung cancer or mesothelioma due to the fact that there is a history of asbestos exposure. So there is a difference between the risk due to the plaque itself or the exposure. After pleural plaques, we need to understand what is so-called benign asbestos-related pleural effusion, or PAPE. So it is exudative pleural effusion in workers who had asbestos exposure, and they may lead to diffuse pleural thickening depending on the volume. Usually it is shorter than pleural plaques, and it may appear within 10 to 20 years. Because of the involvement of the parietal pleura, may be like pleuritic chest pain, could be dyspnea depending on the volume, and it could be either unilateral or bilateral. If there is sufficient volume to aspirate, they may be most likely exudative and hemorrhagic as well. And cytology for malignancy should be clear. The hazard from that is that if we are seeing a middle-aged or an elderly worker, retired worker with pleural effusion of unknown explanation, we need to think about lung cancer or mesothelioma. So it is that the purpose is that pleural effusion is important, but we need to check up for the cancer as a first priority. Lung function may be restriction, as can be seen. The third pathology is asbestosis or diffuse interstitial fibrosis. We can see diffuse interstitial pulmonary fibrosis in the lower lobe predominantly, and in the histology study, we may see ferruginous body or asbestos bodies might be seen in the tissue sample. And latency is very long, similar to others, like over 20 years, and that is dose dependent. The higher the dose, the effects, the extent of the condition would be more severe. Actually, we should expect progressive exertional dyspnea on the clinical examination by basal inspiratory crackles and digital clubbing. Digital clubbings in any patient with respiratory symptom are very dangerous sign for me. So I would rule out any malignancy when I see a clubbing. When we do the scans in the HRCT, there are a few classic findings such as subpleural lines, reticulation, honeycombing appearance, and they may appear in the lower zone predominant. You may also see pleural plaques as well if there is sufficient exposure. Lung function, on the spirometry, we should see classically restricted pattern, and in the DLCO, they should be reduced as well. From there, complications could arise such as progressive respiratory failure, increased risk of lung cancer, or if there is people are living long enough but the heart fail first before the lungs, and we can expect cor pulmonale. Similar to any other exposure, asbestosis is related with increased risk of bronchogenic carcinoma, especially if the worker smokes as well. And then we can link to lung cancer. This is bronchogenic carcinoma. It may be any histological subtype, and risk exposure, accumulative exposure increase the risk, and smoking will have synergistic impact on that. Latency may be 20 to 40 years. The clinical presentation is not different from any other type of lung cancer. So symptoms such as tiredness, weight loss, and non-specific cough would be earlier symptoms. And unfortunately, many people might ignore that as a smoker's cough, and so that could delay the presentation or problem. And dyspnea is usually a late sign, unfortunately. When we do the scan, we should see a parenchymal mass or nodule, and there may be associated pleural effusion or plaques as well. Function may depend on any other underlying lung disease. So it could be obstructive, restrictive, or mixed pattern can be seen. And the last, not the least, is malignant mesothelioma. So it is a pleural mesothelial cells malignancy, and it has strongest association with cryptolite fibers, and latency can be 30 or plus years and can occur with low dose exposure. Clinically, when it starts showing symptoms after 30 years, it may show progressive dyspnea. There will be pain in the chest wall, current unilateral pleural effusion, weight loss. If it is affecting the peritoneum, it might be related to abdominal pain and weight loss as well. When we do the scan, we can expect pleural effusions, nodular pleural thickening, and this is in the circumferential pleural ring, which is encasing the lungs. So usually this is very poor prognosis. Lung function can be mostly restrictive due to the pleural encasement, and prognosis even by today's standard is still poor. Most of the median survival is between 12 to 18 months. The difference between bronchogenic carcinoma and mesothelioma is that mesothelioma doesn't have strong synergistic effect with smoking, and it may still occur with or without asbestosis as well. So in terms of the history, you may find that the mesothelioma patient may not have heavy dose of exposure. So we need to remove that thought of workers who are working in the Whitney mine with massive dose of asbestos exposure. Many of these workers pass away from many conditions before mesothelioma happened due to the dosage of exposure. I'm not saying mesothelioma could not happen, but other things could kill a lot faster than mesothelioma. Obviously, the GHS category of carcinogenicity regarded that as a category 1A. That's all I have to say about asbestos today. The key thing with asbestos is that people we see today in our clinic with the health surveillance may be absolutely fine, and if they're going to have mesothelioma, they might have them in the 30 years or 40 years in the future. So we need to respect the effects of long latency more than anything. And we need to document the findings clearly, and we have to communicate that it is the due process that we are following, but they need to control the exposure as much as possible, apply the hazard control in the strict manner. And the last bit is counsel about smoking. So counseling about smoking is probably the most important thing we can do every time we are encountering with many workers. Thank you for listening, and I hope you find this topic useful. I would certainly have another episode again once I finish my History of Mesothelioma project. Until next time, have a good weekend.